Thank you very much. I'm Patrick Blanshard. I'm the CEO of Sensory Technologies, and really appreciate that everyone was able to come together today. And I know there's people coming and going throughout the afternoon who will be in and participating in sessions. More sound? Okay. Participating in sessions. Just wanted to highlight a couple of pieces before I dive into the formal aspect of the presentation, and that is the multinational nature of the audience. And I think mentally everyone's separating this between English and French as a language, but from a linguistic standpoint, the work being done in the booth in the back is Olympic in nature. We have 1, 2, 3, 4 English-speaking health systems essentially in the room. We have representations and terminology, lexicon, concepts that spread within the United Kingdom between more than one nation in the United Kingdom, Canada, the Dutch system, who is working both in English and of course in Dutch. So there's a lot of dynamic even amongst the English-speaking groups when we get together to try to level set and talk about how does an apple and an apple compare, as we say, apples to apples. And last night, we actually had a Canadian and English dinner and working session, and a very good part of our conversation throughout the night was actually, what does this mean? What does that mean? What is a CCG? What is a CCA? What does a NHS commissioning group do? What does a Ontario LIN buy? How do they purchase things? So I don't expect that throughout today this will become clear to everybody, nor do I think that's really the point of today. But recognize that we have to work around these differences to understand really the fact that we're often working on the exact same challenges. And that's predominantly what I'm going to lay out for us in this next bit of the presentation. But what I ask is, as we're going through the rest of the day, it's a small group, there's a lot of bright minds in here working on these problems in their own jurisdictions, is that we pause and say, I don't understand what that term was. So please, if it's in French in your mind or if it's coming to you in English and it doesn't make sense, let's pause and actually say, what is this? You know, on the map, what was that? Can we back up and correct? That's important for two reasons. One, it'll make sense in the immediate situation, but it'll also help from a linguistic standpoint because we'll actually be teaching ourselves and our linguistic support what the terminology that we're using really means, which will help us as we move throughout the day. Really, I see this as obviously this is sponsored by Sensory Technologies, but predominantly when we're in these types of events, it's a huge opportunity to learn. The benefit for Sensory Technologies is to learn specifically from you, right? The challenges that are being faced, the opportunities to cooperate, how we can support those problem-solving activities. From you as system providers and as health leaders, I think you will find, and it's been very consistent for my personal journey professionally, is that the problems are often the same, the solutions are often very similar, different names, different challenges around them, different terminology, but we're often able to leverage the learning and the activity that others have done to shorten the cycle from 13 years for innovation, maybe down to 5. For us, it's been 10. So we're well into that 13-year cycle ourselves for adoption. But that there's an opportunity for colleagues to build relationships internationally, peer-to-peer, and to leverage each other's hard work. And that's really a big part of it. So this is a two-part activity leading us up to lunch. Presentation and discussion, and actually a technical demonstration. So the technical demonstration is meant not to provide a pathway to how a model gets put in place, but it's to give an example of how a clinical model that's technology supported actually is working. And it's a fairly generic demonstration of what we would do in actually the Ontario space. And from a context setting standpoint, and I appreciate Donna and Kathy staying out of the national space, speaking from the authority of where they're coming from as a LIN leader. To put in context, of course, health services in Canada are national mandated, but they're provided provincially, similar to Germany, right? So there's quite a bit of disparity when you go from province to province. So Ontario to Quebec or to British Columbia, entirely different health systems. The local Minister of Health, so the provincial Minister of Health for Ontario, controls a $52 billion budget. He signs for $52 billion in services that are procured for those 13, 14 million people. That's then subdivided down to the LHIN level and over to the GPs through their insurance scheme and public health. So when you hear about a LHIN, and Donna's LHIN with roughly 1 million, and that's the LHIN that I live in, that's the region I'm from, roughly 1 million plus citizens, it is a very large purchasing area when you look at the number of medical staff, the institutions, the challenges, the political issues. They're not unlike geographically a region that you would look at in France or in England, where you've got a large urban center with roughly 500,000 people in the collective area, and then 500,000 people spread through multiple small communities and across smaller hospital systems. So it's very similar to if we leave Paris and we head north, or we head south, and you start to go across dense urban spread into dense rural area, unlike the middle of Canada, right, where we can spend days driving and not see anybody. Which is often the perception, the foreign perception of what the Canadian experience would be. When you realize the vast majority of Canadians live within 100, 200 kilometers of the US border, it looks like we're basically just hugging it because it's warm. And there's this very small spread out population over the rest of Canada, which creates a very big challenge to provide equitable service at a national level. And functionally, you can't. Right? You can't. They're challenged to try to figure out how to do that. Our primary focus here is not talking about the deep rural population. It's about the local rural population that would be very similar to the populations you would see in the UK and in France and in the Netherlands. So I think you'll find a lot of similarities there, and I encourage you in lunch and in the breaks to break the language barrier. There's quite a few people here that actually are bilingual or trilingual or quadrilingual actually, that will be happy to jump in and pull some people across to talk. I think you'll find your experiences are much more similar than you probably want to believe. It's not any better in any other country. So that's my depressing message for the day. So let's get started. We'll just move to the next slide. So what's the big driver for all of this? And I am going to walk around and point, which is why I was testing this microphone. So this is a Canadian slide specific to the demographic urgency for Canada. So I'll speak first from a Canadian perspective, and then I think we'll go global with this. So for the first time in our history, there's more people over 65 than there is over 50, or under 50. So from a health economic standpoint, our health consumer population, as we would call them, healthcare consumers, users of healthcare, our retirees are greater than our youth. So we're not alone in this. This is not a new phenomenon. You know, we're talking about almost a quarter of our population would be considered seniors, would be considered senior citizens in just 14 years, which puts us on par with Japan, which is the world's oldest population from a developed country standpoint. How would a country like Canada, discounting that giant geography challenge that doesn't actually affect the majority of Canadians, right? The majority of Canadians live in cities and regions just like in England and France and the Netherlands. How at a national level are we going to be able to provide the expected services to that population? Would a Canadian citizen or would a French citizen who's 50 today accept that 20 years from now they're going to receive far less service and poorer health care than their current companion would have down the street now in France? I doubt it. And it's the same challenge in Canada. We're led by politically elected parties who have to respond to their electorate. No one's going to accept that. And we know we can't spend our way out of it because there isn't the money and we don't have the resources. So if we go to the next slide. So as I mentioned, we're not unique. America, we don't have a US contingency here today, but we all know that they spend the most per capita on healthcare, and all of us are generally quite happy to point out that the results don't match the spend, right? Between Canada, the Netherlands, France, and England, we can proudly look at pretty much any US health authority and say, you're not getting what you pay for. And they know that. They're working very hard to try to break this model and figure out other ways to deliver care, they've got some big challenges. But when we look at innovation, pharma innovation, med tech innovation, I mean, that is the big industry. That is the big place where any startup in France usually, or startup in Canada or England, they're looking at the US as a place to sell as well. So they're always worth watching it as a benchmark, not just for who isn't doing best. But when you take a look at the UK, 2 years ago, there was over 500,000 people that were over 90 years old. I'm pretty sure many of them are actually quite healthy, right? There's enough doctors in the room here that by the time you hit 90, you're probably doing pretty well. But arguably, that's a pretty amazing indicator when you think of how many centenarians, how many citizens over 100 we're going to have. And this is a hard slide to see from the back, but this is a percentage of the population over the age of 65 in 2010 and projected in 2050. So France, currently, 2010, 17% of the population was over 65. We're expecting to be 26%. Canada, 14, expecting to be 26%. The UK, 17%, expecting to be 25%. We're talking about the exact same demographic spread. So when we look at the fundamental inputs that drive our activities, this is where it comes from. There's demographic differences, there's health and wellness differences depending on geography, racial background, cultural background. But if we average that out, and we're just looking at simple things like age as a marker for consuming services, and the odds of a chronic complex patient being in their last quarter of their life, we can generally see that we're in quite a bit of trouble. And we all know this. We'll go to the next slide. So the number of centenarians, people over 100 years old, in the UK has gone up by 65% in the last 10 years. There's over 14,000 people in 2015 that were over 100 years old in the UK. And if we look at what's projected in the curve that's currently moving, we're looking at a massively aged population. And if we use the UK, we've already level set across England and France and Canada. And the Netherlands actually isn't much further off. We're going to see an astronomical aged population, which is both that's both a reflection of how well and how different the outcomes have been in the last 20 years with interventive medicine and keeping people alive, and also general health. But that also means if that's the front end of the train, we're pulling behind us a colossal population of high consumers, right? Patients with multiple comorbidities that are going to be consuming an astronomical amount of care in order to maintain their health and to stay alive. And that's the challenge that we're fundamentally facing. We'll move to the next slide. So when we think about these underlying challenges, and yet this is a bit of a silly cartoon, but I think from a demographic standpoint, it is pretty reflective, right? We're essentially a set of cultures that rely on a very large spend of our GDP for healthcare, pillared on top of informal caregivers, family members providing and patients providing self-care in the community. So we're running essentially giant invisible hospitals that are staffed by sick patients taking care of each other and themselves, on top of the actual high productivity output providers of the economy that are paying the taxes and are actually trying to backfill the need. And we have a diminishing population curve relative to the aging population. We talk about these silly terms like in the silver tsunami, or there's different terms in each country and each language to describe the incoming retirement population that's going to be consuming all of these services. And it has never been a surprise. The baby boomers, whichever term we want to use. But it's a real demographic challenge. And against that challenge is a demand from the electorate for transparency and accountability. We spend a lot of money on healthcare. And I don't think whether I'm talking to someone at Mutualité Française or the ARS or Amsterdam Medical Center or in Canadian health system or in the UK, accountability and transparency is a huge driver. Where's money being spent? What are the outcomes that we're getting? Is what's currently working effective? How do we change? Against that, we come up to a lot of common barriers, legislative barriers. The law prohibits a lot of change for a very good reason. They were put in place in many cases to drive funding. That funding was against concepts of how we should socially organize. None of these things change quickly. One of the discussions we had last night was, due to Brexit in the UK, there's absolutely no appetite for parliamentarians to make changes to law because they're consumed with dealing with a much bigger set of social issues right now at the national level. So in Canada, we have elections, of course, like you do, that drive a lot of that cycle. Behind that national, or we'll call it the national level policy issues, we come up against and move within regulatory regimes that govern physicians and nurses and therapists, drug regimes. That whole industry are very often siloed, very effectively siloed, because they're disciplines of science that have their own academies, their own body. They're often quite challenging to develop their own changes and to push forward with their own agendas, let alone to collaborate amongst each other. It's not how they were designed to work. We step further from that into kind of the whole idea of risk. And whether it's liability, like liability insurance risk, which drives a lot of physician behavior in the US and Canada. At the end of the day, individual clinicians are responsible for what happens and have a big say in change. Regardless, we have to come against this inverse population triangle. And that's the reality. And if we set the patient experience in front and recognize that there's a lot of these pieces aren't going to be easily resolved, but regardless, we have to push through it. We have to figure out new ways to do things. We've got to figure out more efficient ways to deliver care. And we recognize that no, which we are, consumer of healthcare, is going to accept less care or poorer care or a reduction in care as an acceptable outcome from a policy perspective, but fundamentally from a practical perspective. And you can very easily take your own national numbers and apply them to your local community and say, okay, in 20 years, how many patients would this hospital have to take on? And it's usually double to triple if you actually just take your demographic curve and turn it up. And it's impossible. Most cities in Canada would have to build an Olympic park equivalent to scale, staff it, and put enough beds in for about a 20-year curve. We have no staff for this and there's no money for it. We know that. And it's the same in France and it's the same in England. So I don't stand here and suggest that our organization has a solution to that. But that's the burning platform, so to speak, that we're all standing on, that is the motivator to drive these types of conversations, to push where change is often difficult to bring to fruition, and to create sustainable models of care that are both high transparency and accountability and have very strong outcomes behind them. And so those are some of the outcomes that we're going to take a look at shortly. We can move to the next slide. So a little bit of a switch to the company itself and why we're all sitting here together and how we've tied this all in. The company's first clinical project was in the Southwest LHIN under Donalada Sewer's former organizational structure, the CCAC, the Community Care Access Center. So we actually started in a regional city of about 500,000, focusing on pediatric complex care. And the concept behind that was, with these children with very high needs and technical dependency to live, a lot of the skill that was required to maintain these children's care was already being transferred to family members. Functionally, the children would be permanently living inside of an institutional environment if they didn't receive that level of care at home. And it was a spread between, and Donna and Kathy can speak to that at lunch, to how those programs work. Those children were receiving essentially permanent ongoing nursing care in their home, as well as supplemented family care on top of it. And so a tremendous amount of activity and skill was transferred to family, who were unregulated and working independently. And if it could be done for a family member, why couldn't it come up into the health system and be taught to an assistant, a nurse assistant? That was the beginning. And we used the technology as essentially an enabler, a safety valve, so to speak, to allow that communication between a remote assistant and a responsible nurse to supervise. And that was kind of the beginning of this entire journey. We very quickly actually moved from 2010 into 2011 into palliative care. So we maintained the pediatric population and then moved into palliative, adult end-of-life care, where the focus was on the final 30 days of life, diverting patients from hospital who were dying in hospital who wanted to die at home. And it was their place of choice. It wasn't being directed. It wasn't under an auspices of trying to save money. It was really around death with dignity in the place of choice. And could patients get supported with advanced needs in their home, replacing a hospital stay, period, where they would previously have been too complex for the traditional palliative care services that they could get in community, and would they be able to actually live out their final days in their home environment. We opened up in the United States in our first patients in 2013. This was our first foray into what's called the Accountable Care Organizations, which is a big US drive, the ACO, Obamacare, which was the idea that they would merge private and public health systems together, and they would go to population management and put in money in the middle. The insurers, the doctors, the hospitals would all form a partnership, and they would target specific patient populations and say, if last year it cost $100 million to take care of this group of patients, this year you get $90 million, but you're going to get paid as a group, and if you actually save the $10 million, we'll split it with you. If you cost more than that $90 million, we're going to cut how much you make. So it was the idea we would say carrot and stick. We'll give them a treat or we'll beat them. And this was the idea. They're failing miserably across the US right now. The organizational structures are being tweaked. There's a lot of complexity in the way the US models work, but it was the first time for us to step into a space where we were really dealing with multiple diseases at one time, and there was an open appetite from a medical perspective to really experiment with what you could do with a supervised assistant, with physician supervision, and nurses working as the hub of the team. And we then took that learning and came back into Canada with it and started working on chronic complex disease management in Canada. In the meanwhile, we went live in the UK with the palliative care population, where the focus wasn't and isn't the final 30 days of life. We're not moving patients out of hospital. We're actually working in a very mature hospice environment that works out into the community. And Sam, it's 2 years, right? Upwards of 2 to 3, or potentially. Last year of life? Am I, just to confirm with the audio, because if I go too close, we go red on the recordings here. Are you able to hear me okay? Yeah? Okay. I'm getting my mixed signals. So outwards of a year of life, and really supporting the greater community team, including the GPs and the district nurses, the independent community nurses, to have access to expert palliative medical advice to affect the outcomes of the patients in that region. So we'll just keep rolling. So when we talk about the different pathways, the different models of care that there's experience in this room today to be able to speak about, and this is where I think we can have some very interesting dialogue this afternoon. Palliative care, both actively dying patients, their final days, palliative care or terminal patient management, or there's different terminologies around whether you would say it's hospice or palliative, but patients who are in a terminal condition and are being treated for a long duration. Pediatric care, and it's complex pediatric care, so mechanically dependent, medically fragile children. And so they're living with machine support, very complex needs. What we would say in the United States is the big four. This is where the American Medicare program is working very, very hard to reduce their readmissions and is actually penalizing the hospital systems that have patients readmitting with congestive heart failure, with chronic pulmonary disease, COPD, with AMI, or pneumonia. And we have a very new model that Kathy will be able to speak to with her region, which is the post-acute stroke rehab. And the post-acute stroke rehab model is the first time we've ventured into care team models that aren't nursing and physician focused, but are neurologist and therapist focused, because it's post-acute, so it's actually physiotherapist, occupational therapist, and speech language pathologists that are doing the bulk of the clinical work with the patients. All of these models are hospital to home. All of these models are really around extending the services of the acute setting, of the hospital setting, into community, and working with the existing patient population to reduce their need to consume hospital services if they can receive that care in the community. Move to the next slide. So to give you some context in scale and some of the outcomes, and we'll hear more about these outcomes throughout the day, there's about 10,000 patients have received service in the last 4 years in these models, and they start quite small. The clinical projects are usually 20 patients, 100 patients before they scale up into a commercially viable or a large-scale deployment by an insurer or a health authority. That said, when we look at some of the larger deployments in Ontario, for instance, we've seen some very tremendous change in the outcome, both from an investment standpoint, so from an insurer standpoint, what it's costing to provide care, as well as an outcome measurement standpoint. And from a reduction in costs, we're averaging somewhere between 30 and 40, 50%, depending on the actual model of care that's being looked at. For the chronic complex disease, Don, I believe we're down almost 50% cost reduction. So this is total cost of care, not just for community, but all including the total journey of the patient over the studied period of time. We're looking at almost a 50% drop in their cost to treat them. For our palliative care patients in Canada, where if they were able to receive in-home services that would have kept them in home, they had a roughly 50% readmission rate. In one of the regions, that readmission rate's dropped to under 2%. So they're not consuming hospital services anymore, and they're able to die in their place of choice. From a clinical perspective, one of the big drivers is the increase in capacity. And we can come up with great algorithms and great clinical models that have better outcomes, but if we're not attacking the problem of capacity, we're going to continue to give better care to fewer people. So capacity is always one of the big drivers behind the projects that we're generally involved in. And on average, we're seeing a 3 to 7 times increase in the number of patients being supported by the responsible clinician. And that's the big term. And that's what we're going to take a look at. How does that actually happen? How can you leverage a therapist or a nurse and not only double the number of patients, but go up 5 to 6 times? So from a kind of a shocking statistic, one of the big steps that we took in Canada, and it started early on, I think, Donna, back with pediatrics, we didn't have a choice. We had to do medication administration. We had to have meds being administered by non-nurses in order for the program to work. Family members are administering medication to the children. So if an assistant was coming into the home to support the family under nursing supervision, they would have to do the same. Medication administration under nursing supervision, in the last 3 years in Ontario, there's been now it's over 60,000 medications that were administered in Ontario by nurse assistants, which would be previously a highly regulated act, and it still is a regulated act. Just like in England and France and in the Netherlands, delivering medication is under the authority of physicians and nurses, and in some cases, pharmacists. So this was a huge step. So we'll move to the next slide. So how is it happening, and what's really the impact on the different actors in the system? So for doctors, whether it's GP or specialists in the hospital and management, there's real-time transparency that's being built in these models of care, and their ability to access information and see what's going on in real time and to be able to proactively involve themselves with the plan of care that happens outside of the hospital, and the ability to access what's happening with their patient population from a planning perspective, to see what's going on, to drive that transparency, and to actually work informed is a big piece, and it's having system-wide command. So Donna will be able to speak to this afternoon, and Kathy, that they can see what's happening across their patient population. I know, Donna, we can talk to the Clarity module and how you're using it in your LIN, and how managers actually are working above the individual patient files and looking at services being provided, the efficiency, the costs, the activities that are being conducted in the community. Many ways as to how nurse management and physician management in the hospital today expect to have that level of resource and reporting within their hospital systems. From a patient perspective, it's often what we're seeing from the research that's coming back, it's about they're receiving care in their place of choice. The fact that in many cases they want to receive it at home is a big win. That they get access to expert care. And even though the models often rely on supportive staff working in the community, the patient sees the direct connection between that staff member and a subject matter expert that's remote. So they know that even though they're working with a nurse assistant, that nurse assistant is directly communicating back with an expert in the specific disease that they're having treated. From a caregiver perspective, and we're using the term caregiver to mean the family and or the supportive staff for the patient, so not the professional services. So from a caregiver perspective, the ability to track stress and to help manage that caregiver as they're providing support for their loved one, to be able to give them tools to help them actually provide care with an enhanced practice, essentially. And when we look at especially chronic diseases, often the caregiver, the family member that's supporting the patient, is as involved in their care in many cases as the medical staff are, and often will have a longer patient journey than the individual medical practitioners that are coming in and out of the patient life. And a high amount of transparency. And that transparency is relevant both for the active caregiver, someone who's hands-on and sitting beside the patient, as well as a caregiver that may be remote, who wants to know from across the country or from a different country how things are going with their loved one. The ability to have access and see what's happening to the patient. We can't forget, and we're talking about the nurse here, but we can say really the registered clinician. So whether it's a therapist or a nurse, ultimately high confidence in the model. These are very disruptive models from a labor standpoint, and we can't discount that. There's quite a bit of work that needs to be done in any model like this around labor, organizational structure, union engagement. Ultimately, our experience to date is that once the models are in place and the staff have had a chance to experience them fully, there's a very high confidence, a very high job satisfaction, and there's a lot of respect for the knowledge transfer. And it's knowledge transfer that's not just happening between the clinical leaders and their assistants, but it's happening laterally. It's happening between different disciplines and their ability to circle around a patient and each other and support learning the spread of knowledge. One of the big challenges that we systematically have in community when we leave the hospital is sharing information and building skill. Right? The hospitals have done a very good job of reorganizing staff, of organizing staff, and of educating their staff continually. And it's a very difficult challenge to do in a community environment where predominantly everyone works independently. In France, independent nursing organizations, right? How do you actually build transparency in a collegial working environment and drive skill? Next slide, please. So one of the illustrations, and this is a very simplified view of what we've done in the US and in Canada to date, in particular in Donna's hospital environment in the Southwest LHIN. We worked to take COPD CHF patients who would normally, and we'll use the real stats in a minute, but generically thinking that they would be on a 7-day length of stay. They would be in the hospital for up to a week, reducing the number of days by half and moving them into home. While they're at home, they're still under supervision and care of the hospital. So the medical authority remains the hospital while they're in community. So big legal change there. At the end of the stay in home, so in the virtual inpatient essentially, and they're being discharged, if they're considered at high risk to readmit back to hospital, they receive additional services for up to 60 days. And the idea behind that was there's no way to just replace the hospital. The idea is to basically merge GP, hospital, community, the whole team together. So from a patient perspective, they're receiving a single point of access. They're coming in and they're being treated as a complete patient all the way through. And we're driving patient interaction to be far more or less about the patient consumer and more about self-advocating and taking responsibility for their care, and to basically take these chronic complex patients who are often stuck in a trap where they're in a constant loop of admitting to hospital, being discharged and back, and to break that down and to show and to demonstrate that the patients can go for a very long extended period of time with GP care supported by high-level hospital service in a way that they can escalate and de-escalate services for the patient without requiring emergency department admissions. Next slide. We're going to take a look at the tools for a relatively short period of time, contextually with a story. The pieces that we're going to focus on are really the core work that sensory tech does, and that's the tools that allow the clinical model to occur. The remainder of the pieces are often found in other hospital system tools, and we provide them because we have to in some cases, but we often work behind. So in the case of if we're working with a large hospital that uses, say, Cerner, right? Cerner has many tools to visualize what's happening with the patient population. We give the data to Cerner to show, right? The pieces that we'll focus on and play with today are the pieces that allow the remote clinician to manage their frontline staff and the GPs to communicate and the hospital staff to work as a collaborative team. And so we're going to actually work on these today. Next slide. This is an intentionally confusing screen that it's even hard for me to read it this close. This is a view of what Donna's organization would see when they log in to look at their visualization tools of what's happening with their virtual care teams. And in this afternoon, we'll actually get to look at some of that data and actually play with how these tools work. You will see as we go into the model and play with and interact, every bit of data that's being collected beyond just the core clinical data, but the environmental data. And when we think about the community and we want to compare it to the inpatient hospital, in the hospital we control for everything, right? The lighting, the temperature, the food, the hours that you can visit, right? How much time is spent with each patient, what rooms the patients are in, what their bedding, what the hospital is laid out like, what furniture is there, right? We, like in a scientific method, control all of these factors. As soon as we step out into community, we can't even control when the meds are being given. It's the patient's choice in many cases. We have no control over the food. We have no control over who's in the home. We have no control over whether the home is the appropriate place relative to the disease that's being managed. So the opportunity to collect information about the environment that the patient is in is incredibly important if we want to have a relevant understanding of the medical information that we're being given. So this is part of the tools that are used to actually visualize what's happening with the patient population in context with their environment. Next slide. So we'll talk a lot about this provocative idea of delegation. And it's provocative in the sense of the way it's applied in the models that we're going to share, but it's a very common procedure that is happening in every hospital system. Senior physicians delegate to lower physicians, physicians delegate to nurses, right? Family members are delegated to take care of their loved ones when they leave the hospital. We're going to use, from a simplistic standpoint, the Ontario regulations around delegation, but when we look at the delegations in France, in England, in Germany, in the US, they're very similar in nature, and there's usually a prescribed list of regulated tasks that can or cannot be transferred down, and if they are transferred, how are they transferred, and who remains responsible. And ultimately, the nurse or the doctor that transfers the skill remains responsible for what is happening below them. That is the true delegation in the sense that you're teaching me, a non-medical practitioner, like a non-doctor or a non-clinician, to do an intervention, and you're giving me the authority to go do the intervention, separate. So what we are talking about is a slight shade of difference. We're not transferring the authority to an individual. They have no autonomy. They cannot go out and deliver one of these interventions independently. The individuals that we're going to be describing, whether it's a nurse working under supervision of a doctor, or whether it's a nurse assistant working under the supervision of a nurse, will not perform one of these skills unless they are directed specifically by the supervising clinician to do it. And we talk about this as cascading delegation. And when we think of it from a hierarchical standpoint, we're talking about generally consultants in medicine in the UK side, so the highest level physician, the highest level medical doctor, empowering generalists, empowering senior nurses to take on additional responsibility and skill. We're talking about senior level nurses working with lower level nurses, potentially with assistants. And we're also talking about what commonly happens already, but formalizing it, where we're transferring skill to family members or patients to do their own self-care, right? So the idea behind the cascading delegation concept, and this is not a new idea, is around having healthcare professionals in the community working to the maximum capability of their licenses. It's commonly happening in the hospital environments today. If we go to a trauma center and we look at how the teams in a trauma center work, they often function entirely around the idea of delegation, the ability to very quickly react and to do things in a very safe team environment. But there's an incredibly high level of supervision, right? That's the difference. The team is working very closely. That often falls apart the second you move into a less intense environment, and it's almost impossible to imagine in the community space where people don't even know each other physically. How would you trust them to collaborate and work effectively and do things safely and make the right decision when it comes to a patient that not everyone's even looking at, right? So this is where we become provocative in the model. Go to the next slide. So a very hyper-simplified caricature of a nurse, but universally, I think, understood. So consider this our independent nurse in the French community, or our district nurse in the UK, or a CCAC or LIN community nurse in Ontario. They generally work alone. So whether they're technically independent or not, they work independently. They work by themselves in the community, 8 patients a day, 10 patients a day, depending on geography. So one of the big challenges we have if we focus on the nursing aspect of discharging patients from hospital is they predominantly need nursing care. They may be under physician oversight, the GP, but it's nurses that are doing the bulk of the work when it's the hands-on work that are being done. And if we're looking at the more complex patients, we require a far greater amount of nursing services for these patients. So the model itself, we'll go to the next slide, is based on the idea that you can take, and I'll use the term loosely, junior nurses, so assistants that are trained up to a level below a nurse, but are supervised by nurses, that are essentially controlled live by a remote nurse, who are able to go into the home and provide a portion of the services that the district visiting nurses would normally do. This, in no case, to our experience today, has replaced nurses in the home. What it's doing is it's supplementing, it's accenting what those standard community nurses can do by giving extra resources to the team. We're taking patients from the hospital system and putting them into community. We're not taking the patients from the community and taking their nurses away. That's a very important distinction. We're taking a more complex patient that would normally not be able to survive in the community environment. We're leveraging the existing nurses that are there now, and we're adding in another layer that reduces the need for hospital service and increases the capability of community to take on these patients. So we'll go to the next slide. So it's technology enabled. The model doesn't work without the technology in the middle, because the nurse that's responsible or the clinician that is supervising live needs to be able to control multiple patients at once, multiple workflows at once. They are essentially responsible for a virtual ward in the hospital. And those wards are organized and stacked together, and those nursing teams can share resources and they can cover off for each other, and they're able to de-risk escalations. Generally have at least 1 to 4. So that's the minimum threshold. We normally see 1 to 4 as a starting point, where you'll see 1 specialist resource supporting 4+ patients at one time. And the technicians, we call this generically, we refer to the staff member as a technician. These technicians are trained on specific clinical interventions, but those are different depending on each country. That's relevant to local law, to common sense, to liability, to all sorts of different factors. But fundamentally, across all of the countries we're talking about, they are trained in observing and reporting what's happening in the home. They're reporting and observing what's happening with the patient, and they're reporting and observing what's happening in the environment. And it's the environmental reporting that often provides some of the biggest benefit to the greater clinical team when deciding how to react and work with this patient. Next slide. Just roll it so there's two filled, perfect. So there's really two ways these models have been, this clinical organization has been deployed. For hospital replacement, the staff are generally going in the home on a shift. 8 hours, 10 hours, it depends on the labor law and the structure. But usually it's more than 6 hours, less than 12, like a hospital shift. And they're actually replacing what would be considered hospital time. Versus moving towards a augmentation model where they're going and doing visits alongside and mixed in with the traditional independent nurses in the community. So this would be a team that would be organized, say, around renal therapy or COPD. So the generalist nurses are doing the visits, but there will also be a supplementary team that focuses on heart and lung problems that's going out and supporting, and is the link back to the specialist heart and lung nursing teams that are actually supervising the specific aspect of that patient care. Next slide. So, sorry, back up one. So thinking back to the model, we're going to go in and take a look at specifically palliative patients, and are we going to see any of the chronic complex as well? I guess we can flip between, we can take a look at what's there. But what we'll do is we'll wrap our minds around an end-of-life patient, and that's a patient who in Canada would be more complex than would normally be supported in the community. So they would die in hospital or in a hospice if they could get a hospice bed. They have asked to die in community. They have a plan of care in place that includes what we would call a DNR, do not resuscitate. So they've given a directive saying they do not want to be resuscitated when they die. And they are receiving care like in a hospice or palliative care hospital environment for usually less than 30 days. I think our average length of stay, Kathy, about 17. Is that about right? It's generally up to 20. Yeah, it really depends on a case-by-case basis, but very similar to what you would see with a hospice environment.